Today's case is Mrs. BF, who is a 78-year-old retired school teacher who presented 2 days ago with prolonged chest pain on a background of multiple risk factors for ischemic heart disease. Mrs. BF noticed gradual onset chest pain 2 days ago whilst out walking. It had a crushing nature and did not radiate anywhere. At its worst, this pain was rated by Mrs. BF at approximately 7 out of 10. The pain was relieved by the ambulance officers after about 1 hour, and it had remained constant until then. It did not change with posture and had no pleuritic qualities. Initially, she took 2 paracetamol tablets when the pain did not settle, however, they provided no relief. A passerby called an ambulance and the pain was relieved by sublingual GTN and morphine. She was pain-free when she reached the hospital, and she has been pain-free since her admission. The pain was associated with sweating and shortness of breath, even when she was at rest. Both of these symptoms resolved when the pain was treated. Normally, she has a good exercise tolerance and is not limited by shortness of breath during her usual day-to-day activities. Mrs. BF has had some recent chest pain that she first experienced 2 weeks ago. It's always been on exertion, never at rest, and never waking her at night. It had always settled within a few minutes when she rested. She has probably had 5 episodes in total over this time. It had a similar quality to the chest pain on admission, although was never quite as severe. Over this time, she's not had any palpitations, symptom of infection, or any overt blood loss. In the emergency department, Mrs. BF underwent a number of tests, including bloods, an ECG, and a chest X-ray. She was told by the emergency department staff that she'd had, in her words, a heart attack. Her usual medications have changed, although she's having trouble remembering exactly which is which. She is not sure what her new medications are for. Prior to admission, she was taking enalapril and atorvastatin. She can remember that she is now taking aspirin. From her chart, the enalapril has been ceased and perindopril 5 milligrams a day has been started. Mrs. BF has also been started on metoprolol 25 milligrams twice a day and full dose enoxaparin. She's due to go home in a few days, but it seems likely that she will have a coronary angiogram prior to leaving, although she's not quite clear on the plan for follow-up. She feels quite tired currently, but does have a number of concerns which we will discuss further shortly. Mrs. BF has a number of cardiac risk factors. She's had hypertension for 25 years, treated with the enalapril. The control over this time has been variable and most likely poor, as she's not attended her GP regularly over this time. She has had hypercholesterolemia for 5 years, treated with atorvastatin. She's not sure of her latest cholesterol results, which was 6 months ago, but apparently it was satisfactory and no other changes were made. She has never smoked, and she has not had a stroke or a TIA, but does have a family history of ischemic heart disease. Her father had a myocardial infarct at the age of 54, which he survived, but he did pass away from a stroke in his 70s. Mrs. BF has no risk factors for acute pulmonary embolus, in particular no recent surgery or overseas travel. She's not had a PE in the past. She's had no symptoms consistent with gastroesophageal reflux. There's been no regular use of non-steroidal medication prior to commencing aspirin. Her past medical history includes intermittent mild asthma for many years, at least 20, treated with a salbutamol inhaler. It has never caused her any major problems, although it can become worse if she has a bad chest infection. There are no other particular triggers. She's never been admitted with this problem or required regular preventer medication. Mostly she takes a Ventolin inhaler via a spacer when she develops a wheeze or shortness of breath. The most recent episode was a couple of months ago. She is not atopic. Past surgical history includes an uncomplicated appendectomy 50 years ago. Systematic questioning was otherwise unremarkable. Her weight's been steady and she has had good energy levels up to this admission. There are no known drug allergies. Mrs. F lives by herself in a 1-bedroom apartment in South Yarra. It's on the 1st floor and there is no lift. She is a widow. Her husband died 3 years ago in hospital, 1 day after cardiac surgery. She is a retired school teacher, having worked as a primary school teacher for 30 years. She has 3 daughters, one of whom never married. They are all very supportive. The 2 married daughters both have 2 children and both families live interstate. The single daughter is in Melbourne, but over the other side of town in Essendon. She's up to date with her immunisations. Her finances are in order. She manages on the pension and has paid off her apartment. And she likes to listen to classical music and has a cat at home. She does consume up to 3 to 4 standard drinks of alcohol each day and has done this for many years, and sometimes more at weekends. She rarely has an alcohol-free day. She's not been a heavier drinker than this in the past. She's not aware of any complications of her alcohol intake, with no known liver disease in particular. She's never had any traffic violations related to excess alcohol. Mrs. BF does not have a history of depression. Her mood is not normally a problem. Her current mood is normal, although she is worried about her future. Currently, her major concern is fear that her chest pain might return. She lives alone and is clearly frightened about the prospect of going home. Also, she's worried about further investigations and whether she might need cardiac surgery. She knows that it's a very big operation and her husband died one day after cardiac surgery. She couldn't describe exactly why he passed away, but it did seem as though it was cardiac related. On examination, Mrs. BF was a pleasant, well-spoken lady sitting comfortably in bed with no oxygen, but an intravenous cannula in her right forearm. She was orientated to person, place and time. Her vital signs were a blood pressure of 120/60, a heart rate of around 60, that was regular. She was afebrile, her respiratory rate was 18, her oxygen saturations were 96% on room air. Her cardiovascular examination was essentially unremarkable. It revealed no signs of cardiac failure, and in particular her JVP was not elevated. Her apex beat was only slightly displaced towards the anterior axillary line in the 5th intercostal space. Her chest was clear. There were no additional heart sounds or murmurs and no peripheral edema. Her peripheral pulses were all present and of normal quality. There was a loud bruit heard over the right side of the neck near the angle of the jaw. There were no other bruits. Her respiratory examination was normal. Abdominal examination was also normal with no organomegaly or masses. There were no signs of chronic liver disease in particular. There was no abdominal aneurysm or renal bruits. Screening neurological examination was normal, but in particular there was no evidence of a peripheral neuropathy. So in summary, Mrs. BF is a 78-year-old retired school teacher who presented 2 days ago with prolonged chest pain on a background of multiple risk factors for ischemic heart disease. She is currently being investigated for consideration of cardiac surgery. On examination, she is well with no signs of cardiac failure. In this case, a good student should discuss a number of issues. Issue 1 is the chest pain. The likely diagnosis is an acute coronary syndrome, but this will need to be confirmed. Possible but less likely differential diagnoses are aortic dissection and pulmonary emboli. Pneumonia would be very unlikely. Associated with this should be the discussion about the management and optimization of cardiac risk factors, particularly the hypertension, as well as the likely need for cardiac rehabilitation. Issue 2 is addressing Mrs. BF's current concerns. She's very worried about her new diagnosis and the possibility that she might need surgery, the same surgery that may well have resulted in her husband's death. She's unclear about next steps and the medication she is taking and why, and these will need to be further explored. Issue 3 is the use of certain cardiac medications, particularly beta blockers, in the setting of a patient who has a history of asthma. The diagnosis of asthma needs to be clarified, and the benefits and risks of this medication should be further discussed with the patient. Issue 4 relates to the incidental finding of a right carotid bruit. This may represent a significant carotid artery stenosis, which likely requires further investigation. The final issue is Mrs. BF's alcohol intake, which appears to be excessive and will require further discussion and investigation. Investigations that are likely to be discussed in this case are Mrs. BF's ECG. This is the ECG from admission when she's pain-free. The heart rate is about 70 and she's in sinus rhythm. The axis is to the left. The QRS voltages are all large, especially through the anterior and lateral chest leads. There are deep S waves in V2 and 3, and some ST segment depression and inverted T waves in V4 to V6. These changes are in keeping with left ventricular hypertrophy or an LV strain pattern in keeping with long-standing hypertension. They could also represent acute myocardial ischemia, but this is thought to be less likely. Serial troponins are normal at admission, but elevated at 6 hours in keeping with acute myocardial ischemia. The chest X-ray is clear with no signs of heart failure. Hello, I'm Dr. Smallwood and this is Dr. Bendrups.
Hello.
And we're your examiners today. If I could firstly just confirm your number, 160344.
Yes, that's right.
Okay, did you have any problems with the case?
No, the case went well, I think.
Thank you. If you'd like to tell us about Mrs. BF.
I saw Mrs. BF. She is a 78-year-old retired school teacher who presented 2 days ago with prolonged chest pain on a background of multiple risk factors for ischemic heart disease. 2 days ago, while walking her dog, she noticed a gradual onset of chest pain. It was crushing in nature, as if someone was sitting on her chest. It did not radiate anywhere. At its worst, the pain was rated by Mrs. BF at 7 out of 10, and it remained constant at this level until it was later relieved by medication given by the paramedics. It was not altered by sitting down and resting. Initially, she took 2 paracetamol tablets when the pain did not settle. However, they provided no relief. Nothing appeared to make it worse, such as change in posture or taking a deep breath or cough. A passerby called an ambulance and the pain was eventually relieved after about 1 hour by the sublingual GTN spray and what sounds like an injection of morphine administered by the paramedics. She was pain-free when she reached the hospital and has been pain-free since admission. The pain was associated with sweating and shortness of breath, even when she was at rest. Both of these symptoms resolved when the pain was treated. Normally she has a good exercise tolerance and is not limited by shortness of breath during her usual day-to-day activities. Mrs. BF first experienced chest pain 2 weeks ago. It has always been on exertion, never at rest and never waking her at night. It had always settled within a few minutes when she rested. She's probably had 5 episodes in total over this time. It had a similar quality to the chest pain on admission, although it was never quite as severe. Over this time, she had not had any palpitations, symptoms of infection or blood loss. In the ED, Mrs. BF underwent a number of tests, including an ECG, blood tests and a chest x-ray. She says that she's been told that she's had a heart attack. Her medications have been changed, although she's having trouble remembering exactly which is which. Prior to admission, she was taking enalapril and atorvastatin. She can remember that she is now taking aspirin. From her chart, the enalapril has been ceased and perindopril 5 mg daily has been started. Mrs. BF has also been started on metoprolol 25 mg twice a day and full dose enoxaparin. She's due to go home in a few days, but may be having a coronary angiogram prior to leaving, although she's not quite clear on the plan for follow-up. She feels quite tired currently and, as I mentioned, she has had no further episodes of chest pain. So with regard to her cardiac risk factors, she has had hypertension for 25 years, treated with enalapril. The control over this time has been variable as she has not attended her GP regularly. She has had hypercholesterolemia for 5 years, which has been treated with atorvastatin. She's not sure of her last cholesterol result, which was 6 months ago, but apparently it was normal as no changes were made. She has never smoked and has not had a stroke or TIA, but she does have a positive family history. Her father had a myocardial infarct at the age of 54, which he survived. He died in his 70s of a stroke. Mrs. BF has no risk factors for acute pulmonary embolus, in particular no recent surgery or overseas travel. She has not had a PE in the past. She has had no symptoms consistent with gastroesophageal reflux, such as acid rash. She has not had regular use of non-steroidal medications prior to her starting on aspirin this admission. Her past medical history includes intermittent asthma for many years, at least 20, treated with a salbutamol puffer. It has never caused her any major problems, although it can become worse if she has a bad chest infection. There are no other particular triggers. She's never been admitted with this problem or required regular preventer medication. Mostly she takes a Ventolin inhaler via a spacer when she develops wheeze or shortness of breath, and the most recent episode was a couple of months ago. Past surgical history includes an uncomplicated appendicectomy 50 years ago. Systematic questioning was otherwise unremarkable. Her weight has been stable and she has had good energy levels up to this admission. She has no known drug allergies. Mrs. BF lives by herself in a 1-bedroom apartment in South Yarra. She lives on the first floor and there is no lift. She is a widow. Her husband died 3 years ago in hospital one day after cardiac surgery. She's a retired school teacher, having worked as a primary school teacher for 30 years. She has 3 daughters, one of whom never married, who are very supportive. The 2 married daughters each have 2 children and live interstate. The single daughter lives in Melbourne, but across the other side of town in Essendon. She's up to date with all of her immunisations and she has never taken illicit drugs. Her finances are okay. She manages well on the pension and has paid off her apartment. She likes to listen to classical music and has a cat to keep her company. She does consume up to 3 or 4 standard drinks of alcohol per day and has done so for many years and sometimes more at weekends. She rarely has an alcohol-free day. She has not been a heavier drinker than this in the past. She's not aware of any complications of her alcohol intake, with no known liver disease in particular. Mrs. BF does not have a history of depression and her mood is not currently an issue. Her current mood is okay, although she is worried about her future. Currently, her major concern is fear that her chest pain will return. She lives alone and is clearly frightened about the prospect of going home. Also, she's worried about further investigations and whether she might need cardiac surgery. She knows that it's a very big operation and her husband died one day after cardiac surgery, although she could not describe why he passed away other than apparently his heart was the problem. So, on examination, Mrs. BF was a pleasant, well-spoken lady sitting comfortably in bed with no oxygen but an intravenous cannula in her right forearm. Her vital signs were a BP of 120/60, a heart rate of 55 that was regular. She was afebrile, her respiratory rate was 18 and her oxygen saturations were 96% on room air. Her cardiovascular exam was unremarkable. It revealed no signs of cardiac failure. In particular, her JVP was not elevated. Her apex beat was not displaced and her chest was clear. There were no additional heart sounds or murmurs and she had no peripheral edema. Her peripheral pulses were all present and of normal quality. There was a loud bruit heard over the right external carotid artery, but no other bruits in her neck or periphery. Her respiratory exam was unremarkable. There were no signs of chronic airways disease or pneumonia. Her abdominal examination was normal with no organomegaly or masses present. There were no signs of chronic liver disease. There was no abdominal aneurysm or renal bruits. Screening neurological examination was normal, but in particular there was no evidence of a peripheral neuropathy. In summary, Mrs. BF is a 78-year-old retired school teacher who presented 2 days ago with prolonged chest pain on a background of multiple risk factors for ischemic heart disease. She's currently being investigated for consideration of cardiac surgery. On examination, she is well with no signs of cardiac failure. With regard to the differential diagnosis of her initial presenting complaint, I think the most likely diagnosis is that of an acute coronary syndrome due to myocardial ischemia. Other diagnoses that are less likely but I would like to exclude include aortic dissection, pulmonary embolus and pneumonia. I think she has 5 main issues which I would like to list and then discuss further. So issue 1 is the chest pain. The diagnosis needs to be clarified, but as I mentioned, I believe it is related to an acute myocardial infarct. If this is indeed the case, then it will require ongoing management, possibly even surgery and control of cardiac risk factors. Issue 2 is addressing Mrs. BF's current concerns. She's very worried about her new diagnosis and the possibility that she might need surgery, the same surgery that may have resulted in her husband's death. She is unclear about next steps and the medication she is taking, so this will need to be clarified. Issue 3 is the use of a beta blocker in a patient who has a history of asthma. This diagnosis of asthma needs to be clarified and the benefits and risks of this medication need to be further discussed with the patient. Issue 4 relates to the incidental finding of a right carotid bruit. This may represent a significant carotid artery stenosis, which requires further investigation. Issue 5 is Mrs. BF's alcohol intake, which I believe to be excessive and may require further discussion and investigation.
Thank you for that summary. Perhaps we can begin with the first issue. Can you please tell me why you think this lady's most likely diagnosis is an acute coronary syndrome?
Yes, I believe that Mrs. BF has an acute coronary syndrome for a number of reasons. She describes a history of chest pain that would be typical for myocardial ischemia. It was crushing in nature and in the anterior chest. It did not change with posture or have any pleuritic qualities. Some earlier episodes prior to admission sounded typical of unstable angina. However, there were no symptoms of infection or palpitations that may have contributed to the development of angina. Also, she has a number of cardiac risk factors, including long-standing hypertension, hypercholesterolemia, and a strong family history. Also, she was told by the ED doctors that they think she has had a heart attack, although I would like to confirm this.
So are there any other differential diagnoses you would consider in this patient?
I do not think any other diagnoses are particularly likely. A large PE could present in this way and needs to be considered. However, she has no risk factors for this condition and has not been hypoxic that I'm aware of. A pneumonia would be unlikely to present with this sort of chest pain, and I would expect other symptoms such as cough and fever. Also, there are no focal respiratory signs in keeping with this condition. Gastroesophageal reflux or peptic ulcer disease might mimic myocardial ischemia, but it seems unlikely in this instance. It is also important not to miss a thoracic aneurysm, but this seems unlikely, and I'm sure she would have had some urgent treatment if this had been the cause of her problem.
What investigations would you have done at the time of her presentation to help confirm your clinical suspicions?
My initial investigations of this lady when presenting at the ED would be an ECG. I think it would be important to rule out an ST elevation MI, as she would need urgent intervention. I would also include some simple blood tests and a chest X-ray. I would be looking for signs of anemia or leukocytosis in the full blood test. I would measure serial cardiac enzymes, as the initial ones may be normal and only peak after admission. I would do electrolytes and renal function to make sure potassium is normal. It will also be an important baseline result if we're changing medication and might need to use diuretics, which could affect renal function. On the ECG, I would be looking for rhythm abnormalities and signs of ischemia, especially ST elevation or depression, or new conduction abnormalities. On the chest X-ray, I would be looking for signs of cardiac failure, the appearance of the thoracic aorta to make sure it's not too wide, and evidence of pneumonia.
Okay, well this is Mrs. BF's ECG. Could you please describe and interpret your findings?
Okay, this is the ECG of Mrs. BF. Her heart rate is 70 in sinus rhythm. The axis is to the left. The QRS voltages are all large, especially through the anterior and lateral chest leads. There are deep S waves in V2 and V3 and some ST segment depression and inverted T waves in V4 to V6. I haven't measured this exactly, but these changes would suggest left ventricular hypertrophy or an LV strain pattern in keeping with long-standing hypertension. They could also represent an acute myocardial ischemia, but she was pain-free, so probably not in this case.
Thank you. Does this help you with your diagnosis?
If this is all LVH, then it doesn't rule out a myocardial infarct. We need to confirm any myocardial damage with serial cardiac enzymes.
Okay, well, I can tell you that the initial blood tests and chest X-ray were all normal. The repeat troponin, however, at 6 hours was significantly elevated. Again, does this help you with your diagnosis?
This would be in keeping with a non-STEMI and fits within the clinical picture. A large PE may also cause an elevated troponin and chest pain, but as I mentioned before, I believe there are no other clinical features to suggest this diagnosis.
So if this is an acute non-STEMI, what are the important management principles for this condition?
Mrs. BF is now pain-free, so she does not require analgesia. She should be monitored in the CCU for the next 2 days and fully anticoagulated at this time. She has commenced aspirin and a beta blocker, which both reduce the likelihood of further cardiac events. It is likely that she will need further investigation to determine the full extent of her ischemic heart disease. She is not quite sure, but it appears that she is currently waiting to have a coronary angiogram this admission. The results of this test will determine whether she needs some form of revascularisation procedure or coronary surgery.
Okay, Dr. Benjamin.
Thank you. Are there any other considerations regarding Mrs. BF's ischemic heart disease?
It'll be important to check Mrs. BF's cardiac risk factors. I would like to know any recent cholesterol values that her GP might have. Her blood pressure is currently fine with her new medications, but this will need to be monitored. The ECG suggests left ventricular hypertrophy, so her BP control may well have been poor for some time. It will be important as well to educate Mrs. BF about her medication, as she currently has quite a poor understanding. Also, she might benefit from a cardiac rehab program. I think an echocardiogram would also be of benefit to determine whether there has been any significant myocardial damage in the setting of the recent non-STEMI.
You mentioned some concerns about using a beta blocker in this patient. Why is that?
Well, patients with asthma have a relative contraindication to the use of a beta blocker. I think it'll be important to check the diagnosis of asthma in this patient.
From your assessment today, do you think Mrs. BF has asthma?
I believe she does. The condition came on as an adult, which is not uncommon, and it is intermittent. The symptoms of wheeze and shortness of breath are in keeping with the condition, and she improves with Ventolin. Chest infections are a clear trigger for her symptoms, which would also be in keeping with asthma.
How else might you confirm the diagnosis of asthma?
I would contact the GP, see if there are any old lung function results and just how the diagnosis was made, i.e. was there any reversible airflow obstruction? A bronchial challenge test could be performed, but I don't think it's necessary in this case.
So in this case, do you think we should use a beta blocker?
On history, the diagnosis of asthma seems likely, but the condition appears to be very mild. On balance, I think it's safe to use a beta blocker in the setting of the acute myocardial infarct, as it has important benefits in preventing cardiac complication.
So you mentioned Mrs. BF's current concerns. Would you like to expand on those issues and what would your plans be to help?
Yes, Mrs. BF is very concerned about her new diagnosis. Her husband had ischemic heart disease and died the day after his operation. She's worried that this might happen to her. She found the chest pain very frightening and is worried that it might come back. She lives alone and, despite having a good relationship with her daughters, feels very isolated at times. I think it will be important to reassure her that it's likely that her medication will be able to control her symptoms. Also, that she might not necessarily need the operation, although further tests will be required to define this. I think it will be important to reassure her that it is likely that the medication will be able to control her symptoms. Also, that she might not necessarily need an operation, but further tests will be needed to determine this. It might be a good idea to talk to her family about her concerns, and perhaps she could stay with her daughter for a week or so after discharge so that she can regain her confidence. A pulmonary rehab program might also help with education and give her more confidence as she can spend time with other people who are dealing with similar issues.
Okay. Can you discuss the issues you've identified regarding Mrs. BF's alcohol intake?
Yes, Mrs. BF drinks 3 to 4 standard drinks a day. She drinks mostly wine. I didn't have time to look into this in detail, but I believe this is more than is recommended for Mrs. BF. She also drinks more with friends on the weekend occasionally. I could not elicit any signs of chronic liver disease or other complications of prolonged alcohol intake, but I believe this should be explored further. I'm not aware if Mrs. BF sees this as a problem or whether she's willing to cut back.
So what would you recommend to Mrs. BF about her alcohol intake?
I would recommend no more than 1 to 2 standard drinks per day and at least 1 alcohol-free day per week. If there is any evidence of cirrhosis, then stopping alcohol altogether would be advisable.
Okay, thank you for your time. We're done now.
Thank you.
Thanks very much.
Cheers.
Bye-bye.
Bye.